This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients. Welcome, everybody, to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi, and I know what you're saying. Where have you been? It has been a busy now 5 months where we have not released any episodes. I am sorry. We are still here. We are still doing this. This is still a thing. What's been happening to us is what's been happening to you. If you're listening to me, you're probably in the pediatric hospital business, and we have the same kind of issues where we're now super busy, much busier than we normally are this time of year. I'm the fellowship director here in Pittsburgh, and we've had a lot of stuff to do for our fellowship. We graduated our second fellow ever, so congratulations to Dr. Slater, who's moved on to wonderful things. We welcomed our fourth fellow ever, so congratulations, Dr. Taft. In addition, on a personal note, I saw my parents for the first time since this pandemic started, twice now. And I saw my in-laws for the first time since this pandemic started, which was a super wonderful experience, and we missed them a lot. Glad to do that. But now we are back, and we are back with a vengeance. We have about 4 or 5 episodes I want to put together and get released out to make up for the time that we missed. This one, I've been so interested in doing this because I have been seeing this more and more, and the data fascinates me. So what we're going to talk about today, before I introduce our special guest, is hypothermia in infants. And by infants, I mean infants under 60 days of age. We see this a lot. I feel like I've seen it a lot, and I've always been wondering, what is the data behind this? What should we do? What should we not do? Do we actually know? So without further ado, I'm going to introduce our guest to help us with this episode. And I could not think of anybody better. We thank you so much for your time. Dr. Andrew Nowalk, friend of the podcast, has been on before for our Lyme episode. Dr. Nowalk's an associate professor of pediatrics and clinical director in the Division of Infectious Diseases in the Department of Pediatrics here at UPMC Children's Hospital of Pittsburgh and at the University of Pittsburgh School of Medicine. He's a 1999 graduate of the MD PhD program at the School of Medicine. He completed pediatric residency and ID fellowship training here at Children's before joining the faculty of the School of Medicine in 2005. He maintains clinical practice and an active research program in Lyme disease and serves as co-program director of the pediatric residency program. He's participated in data science research in diverse areas, including management and diagnosis of the febrile and hypothermic infant. So, Andy, thank you so much for joining us.
Tony, thanks for the invitation. This is an area I've enjoyed looking into before, and I think it's a perfect topic for a hospital medicine podcast.
That's great. So I'm going to start, and I don't often do this, but Andy, we're going to start with, we have to do our conflict of interest statements and disclosures. Let's do that first. I'll go first. I'll kick it out to you. I have nothing to disclose relevant to this podcast.
And I have nothing to disclose relevant to this podcast, other than that, I've published some papers in this area before.
That's a great segue because we're going to start with one of your papers on this.
Mm-hmm.
So we're going to start with the brief report in the American Journal of Emergency Medicine 2019, volume 37, titled Factors Associated with Serious Bacterial Infection in Infants Less Than or Equal to 60 Days of Life with Hypothermia in the Emergency Department. The first author is Ram Gopal S., then Lauren Walker, then Melissa Vitale, and then you.
Yeah.
So I have to tell you, I really like how you started this because too often in medicine, we are all taught certain things that we kind of accept as gospel and are always true. And one of those things is a hypothermic infant is sicker, there's concern for them being sicker than a febrile infant. You start in the intro by explaining some of the data that's behind that as our idea of hypothermia in infancy that suggests this high rate of infection. You discuss how some of the studies were done in resource-poor regions. And the intro for one of the other articles we're going to discuss, hypothermia in young infants, which was in Peds Emergency Care in 2020 by Michelle Parry et al., also done in Pittsburgh for full disclosure, talks about it as well, where they talk about one of the studies was in Baghdad, in one of the poorest areas, 1970, 1980. Dr. El Rahadi reported a 60% rate of infectious etiology for hypothermia of infants less than 4 weeks old, but that's hard to be generalizable in the U.S. You also mentioned how recent studies evaluating these infants with hypothermia have been limited by small sample size and potential confounding. So I like how you set the stage for we may not know what we think we know.
Yeah, I think this is an interesting topic for that reason, Tony. And I'm happy you started off with our paper and Michelle Parry's paper, which are coming from the same set of kids, right? And yet are going to have different results in some ways. And so this is a great example of an area of research where defining the population and how you select it, you have got to read the methods part of this paper and every paper like this really carefully. And this gets back to something you and I have talked about before. What's hypothermia? Where does it start? And, among the papers we're going to discuss today, we have some that are going to start it at 36.0 and some that will start it at 36.5. So right off the bat, definitions here of the age of the infant is the easy one, because when we all talk about febrile, non-febrile, and other infants, now we're almost exclusively talking about studies of infants less than 60 days old. But after that, this is a really diverse set of infants that we're looking at. And we chose in our paper to look at 36.0. And, although there are other definitions out there, I think we're looking for a little bit more of a rigorous group there. And we also chose to look at infants within our emergency department with granular data we can look at. Some of the studies that we may talk about today include things like the FIS database. And the FIS database is a great database. There's amazingly impactful research that comes from it. But for this particular problem, I think having really granular clinical data on each of the infants, rather than, say, data that's driven by a billing code, data that's driven by isolation of a specific organism, is important. And then my final point about the generalizability of settings. Remember, as I chant to all the residents over and over again, geography is destiny in pediatric infectious disease. And that does apply a little bit even to the under 60-day-old infant. While Group B strep and E. coli cause disease the world over, you may, in different settings, whether you're talking about, Southeast Asia, Southwest Asia, Africa, or other settings, you may actually see some other fairly endemic organisms in the community be responsible for twisting the epidemiology of neonatal sepsis. And so always things to keep in mind as we look at this paper. But when we were studying this, we really wanted to address this question. There are lots of older data, but what does a contemporary data set of infants coming into an emergency department in the United States in this setting look like?
That is fast. Yeah, the question of first, what is hypothermia? It's surprising to know that we really don't have a strict definition. I mean, the one paper, Hypothermia in Young Infants by Michelle Parry et al., she laid out really the three ranges of definitions. Well, first, the WHO has a mild, moderate, and severe category. Severe is less than 32 degrees Celsius. Mild is 36 to 36.5 degrees Celsius, which is where most people sit on it in terms of that range. The International Pediatric Sepsis Consensus, which is what you guys used for your paper, considered 36 degrees Celsius as the threshold. But it seems to me that the first thing we have to all agree on is, what is it? Like, what are we calling hypothermia? And we don't agree on that at all.
That's okay. I think, particularly when we look at these data sets, one of the things that I think you do a lovely job on this podcast of doing, and one of the things that's critical for everyone in hospital medicine and infectious disease as well, is to be able to take a data set and to be able to apply it with rigor, but not with stiffness to what you're doing. To say that I read this paper and their definition was 36.0 and below. And so I'm not even going to think about hypothermia between 36 and 36.5. These data give you some nice general epidemiology of what the rates of sepsis are in these various temperature categories. And I think that can guide clinical decision-making in a very nice way. This is always, of course, something that would be improved with something like a PCARN study of the febrile infant, where you have a multi-center approach and you have lots of infants with rigorous entry criteria, and you're looking more prospectively at data that describes rates of sepsis. Ultimately, all of the data we're going to talk about today are retrospective looks, and they have all of the errors that plague retrospective studies. And yet, they're super informative, I think, in describing this epidemiology.
I agree, but let's dive into your paper then. Sure. So you guys, your study aimed to identify rates and risk factors for serious bacterial infection among infants presenting to the emergency department with reported or documented hypothermia. Additionally, you aim to identify the rates of mortality and herpes simplex infections in this population. That's another thing we think a lot about. Hypothermia, a lot of people think immediately of HSV infections. So your method, like you said, single-center retrospective study, infants less than 60 days of age who received testing for SBI between January 1st, 2006 and December 31st, 2017. The inclusion criteria was hypothermia defined as, like you said, less than 36 degrees Celsius, prior to arrival, or within the first 4 hours of arrival, the first 4 hours, and only rectal temps were included. Your exclusion criteria, someone that could not be assessed for SBI due to lack of blood culture or received antibiotics prior, or if they came as a transfer or a cardiac arrest patient. They were all excluded. So then you did a multivariate analysis to look at, identify, and of the risk factors for SBI in infants less than 60 days old with hypothermia. What was interesting that you guys found, so things that were independently associated with serious bacterial infection in your studies. First, presentation during 15 to 28 days of life in these kids, which you talked about in your discussion some, because you initially think of serious bacterial infection in infants as younger infants being more prevalent. Here in hypothermic infants who would get SBI, you found it in the older ones, 15 to 28 days. It's odd to say older for that group, but that older group, which I found interesting, and it wasn't a small difference. This was like, if I want to get the numbers right.
Odds ratio was 4.5 fold.
Yeah, it was significant.
Yeah. And the multivariable odds ratio was 7.5 fold. So it was whether you look at a p-value or for an odds ratio, as I'll always do, is make sure it's not crossing over 1. They really were both outside of 1 and significant. So we thought about this a lot. And, Tony, when I think about changes, when we think about the 70s, I try to think what's different now than the 70s. And I think one of the things that we noticed in our paper was that the very aggressive management of hyperbilirubinemia, a lot of hyperbiliary babies coming to an emergency department, getting assessed with much more frequent visits with the pediatrician in this day and age. Think now about how frequently we often have multiple pediatrician visits early on for those babies. Maybe one of the factors that confounds things here, because when we looked at that 0 to 14 day age group, there were just a ton of cold billy babies in there, just a ton of them. And, the rate of sepsis in those infants was lower. And so I think that this is an interesting observation on this data set, in that there's probably not a dramatically decreased rate of sepsis in that group. It just gets clouded with a lot of fairly healthy babies who enter the emergency room and get a workup simply because they're sent in there for a diagnosis of hypobilirubinemia. And when we look at hypobilirubinemia in our cohort, in the all-patient cohort, it was about a third of all the babies in our cohort had hypobilirubinemia, and so. I think that speaks to some degree the frequency with which they came in. But those hyperbilly babies were disproportionately located in the no SBI group. So, only one of the infants in the SBI group had hyperbilly. And so it was a much lower percentage of that overall group. So I think when we tried to take the camera lens back out and say, why are we observing this? We're observing this because so many babies with a low temperature are coming to the emergency department for another reason. And I think that shouldn't make you never work up a baby with hyperbilly. But I also think it makes the diagnosis of hypothermia in that first 2 weeks something where I might move away from that automatic assumption that this baby has a really high rate of sepsis.
You know, it's interesting you say that because the other paper we're going to look at eventually, Hypothermia, a Sign of Sepsis in Young Infants in the ED by Catherine Kasman et al. In Peds Emergency Care, March 2021, volume 37, number 3, also pulled out hypothermia as one of the things that babies with hypothermia will come in with hyperbilirubinemia. Mm-hmm. And those two things seem linked with these kids. And I wonder if there is, you can think if it's breastfeeding jaundice, the child may be dehydrated, and that dehydration may make them more prone to having hypothermia because they're so young, they're within the first week. And maybe that's just the only link. But it's interesting that they're so connected, hyperbilirubinemia and hypothermia.
Yeah, it's, and I wonder if it's not, they're both surrogate markers for age. I think this is a really important finding in the Perry paper as well. If you look at the mean age of the infants with serious infection and not serious infection that were hypothermic, the mean age was higher, not lower, higher for the infants who had serious infection. That goes against everything that we've ever seen with infants who have fever. So if you're febrile, the age that you're febrile at is very predictive inversely with your rate of sepsis. So a 1 to 2 week old is going to have a hugely higher rate of sepsis than a 3 to 4 week old, than a 5 to 6 week old, than a 7 to 8 week old, to the point where in the old days when I was a resident, we admitted everybody under 3 months old, and then we realized that those babies almost never have sepsis. So age and sepsis rates are strongly inversely proportional for the febrile infant, and yet it's a different distribution for the hypothermic infant. And I think that's just all a surrogate for the poor temperature control of a newborn. When are you most likely to have hypothermia? When you're a newborn. When are you most likely to have hyperbili when a newborn? When are you most likely to have weird breathing patterns that freak out parents, me included with my first one, when you're a newborn? And so I think a lot of these things all correlate with that, and the fact that with a really strong emphasis on hyperbilirubinemia in management, a lot of those newborns are going to end up in the emergency department, right?
You're right. And they're going to be seen, because now especially a lot of times it's urgent care ED, and if it's a baby, they're going right to the ED.
Right.
And it's interesting you bring up the febrile infants, because your rate in your paper, the rate of SBI, serious bacterial infection, in infants overall was 2.8%, which is significantly lower than febrile infants. Yeah. So for hypothermic infants, the rate of SBI in your paper was 2.8%. The numbers that I've seen quoted over and over again for febrile infants is, I don't know, somewhere between like 8 and 14%. I'm looking for it now.
Yeah, I think that's a reasonable. That's in the ballpark. Again, it depends on how you design the study, but I think we can all agree that somewhere between 5 and 15% is the rate for febrile infants.
So it's just a significantly lower number, which is it's nice, but it goes against everything we were taught that cold babies can be worse babies.
Yeah, and I think that this is one of the beauties, and I'll speak to hospital medicine folks out there who think, I don't have time to do research. Just find a question that bugs you and take a peek at it, because these papers also speak a little bit to the power of a single center study well done. 3 of the 4 papers that we talk about today really speak well to the granular data that you get at individual centers is often something that can tell you an important lesson. And I'm a huge fan of the FIS database, and I think it teaches us amazing lessons on a constant basis. But billing code-based research has its limits in the same way as single center studies do. And this is a great example where taking a rigorous look at these patients helps inform us in our care.
I think you're right. And I think especially Catherine Kasman's paper done out of Connecticut is another excellent example where they really get into the nitty gritty and give us information that we can really use. So let's get into Michelle Perry's paper, and then we'll move into the Catherine's paper.
Sure.
So Michelle Perry's paper, Michelle Perry et al., We said hypothermia in young infants, frequency and yield of sepsis workup, and this was also done in Pittsburgh. Again, they go over the incidence of SBI in infants is roughly 9%. We talked about how they said the data in the past it may not be generalizable. They picked as their objective was to determine the incidence of SBI discovered during the evaluation of infants less than 60 days old presenting to the pediatric emergency department with an initial temperature demonstrating hypothermia. Again, done at Children's Hospital of Pittsburgh. The children's age was 0 to 60 coming to the PGD between January 2013 and December 2014 with an initial rectal temp of less than 36.5 degrees Celsius. Chart reviews were done by one of the 4 reviewers. Their exclusion criteria were a chief complaint of trauma, transferred from outside hospital following evaluation for an SBI, or temp was not rectal. So similar to your exclusion criteria. The data was under an SPSS database. SBI evaluation was defined as a full eval as blood, urine, and CSF cultures. A partial eval is less than those 3 cultures. Here's one of the areas I want to discuss with you. Their definition of UTI, and when you get into the nitty-gritty of these methods, you begin to wonder and look at these definitions a little bit closer. The UTI here, they define as a urine culture with greater than 50,000 colony-forming units per ml of a pathogen, which I agree with, or 10 to 50,000 colony-forming units per ml of a pathogen with a UA positive for UTI, which they define as either positive glucosidectorase, positive nitrites, more than 5 white blood cells per high-power field, or bacterial on gram stain. So that second part of that definition, that 10 to 50,000 with the UA, I did not assume that. I would not think, if I had that patient, I wouldn't necessarily think that that's a UTI. Is that something that's done, and why?
So I think that is, from an infectious disease specialist point of view, not something I would define as a UTI. And I think in this study, one of the things that is challenging for me is I would like to know how that urine was acquired. 10 to 50,000 colony-forming units with a positive UA is something I would consider, but I'd also like to know about the method of collection. Calf UAs are always something that we're going to trust a little more. And I'd say suprapubic even more than that, but when's the last time anybody did a suprapubic aspirate? That just doesn't happen anymore. But, I'd like to know what's clean catch and what's catheterized, because we know that clean catch has a lot higher rate of false positive results. And we also know that, clean catch in an infant when someone puts a urine bag on is something I'd like to know a little bit about. But I have to say, I look at that and I acknowledge that tells me they have a broader definition of UTI than I would normally use. And then I move on. Doesn't poison the study at all for me. It's an informative piece of the evidence to say they're going to broaden their definition of UTI, which, as we well know, the most common SBI in an infant is always going to be UTI. So they're going to probably jack up their UTI numbers a bit almost immediately by choosing that definition. And that's really all that the only thing that I would look at that carefully. Okay.
Because to me, when I see that, I say the same thing. The UTI numbers are going to be higher, but I look at it as like, well, will all their numbers then be artificially inflated because that's a part of your SBIs. But I like that it doesn't color it for you too much.
It doesn't dramatically. So I think this is still interpretable. And when you look at this paper compared to ours, this is a 2-year look, but they went up to 36.5. And our paper was a 12-year look, and we only went up to 36. So unsurprisingly, in their paper, they had a lot of kids who didn't get an evaluation, and so were excluded from the study. And they have a lovely figure in here showing who got evaluated. And unsurprisingly, between 36 and 36.5, a ton of infants who were hypothermic in that range didn't get an evaluation. And I think that shows you that there is a lot of confusion, as you and I have already discussed, about what hypothermia means. And in our paper, the vast majority of infants got an evaluation, which agrees with their distribution below 36.0. The majority of their infants below 36.0, by I think figure 2 in their paper, got an evaluation. So, I think this just speaks to different looks at the same database.
So their primary outcome was diagnosis of SBI based on positive blood, urine, or CSF culture or chest X-ray. Secondary outcome was factors predictive of SBI evaluation and SBI diagnosis. For analysis, they used the Fisher exact test and Mann-Whitney U test, and they had odds, ratios, intervals were calculated for categorical data. So in their data, in 2013 and 2014, 487 infants presented to the PZD with initial temp of less than 36.5. 15% of those, or 73 patients, were excluded because they didn't have, for various reasons, they didn't have rectal temp, trauma, etc. 25% of the patients, 104, underwent an SBI evaluation. So this is what you were saying. The remaining 75%, or 310 patients, had no cultures drawn.
Yep.
None of the 310 patients who did not undergo an SBI evaluation returned within 72 hours of subsequent diagnosis of SBI. And for those listeners who don't know Pittsburgh well, we are the only children's hospital. If there's ever some EDs will still do some evaluations, but then they'll send them to us to have the child admitted to our hospital. So if they had it, they would have come here, short of leaving the state to visit family in Ohio, West Virginia, or New York, which is interesting. It's so many kids.
It's a lot of kids that didn't get the evaluations. And, I think that speaks to the role of physician judgment. There's a strong reason why in the original Rochester criteria and most febrile infant evaluations, one of the criteria for an infant who is low risk is looks well to an experienced physician. Yeah. So I think that this speaks to the fact that you have 3/4 of these infants didn't get an evaluation despite technically being hypothermic. Not a single one came back. That fits very well with data we know from the pediatric research in office settings from the 2000s, showing that in an office setting, a general pediatrician is really good at detecting infants who need to go in for a workup when they have some low-grade temps. And this is a shout out to my colleagues, you included. Being a pediatrician gives you a good spidey sense of what you may need to do and also allows you to be judicious in who you need to do the big workup on.
Well, I'll take the compliment. Thank you, Andy.
You're welcome.
So we're going to, now in their subset of patients who received an SBI evaluation, 42% or 44 patients only had 1 or 2 cultures obtained. 58%, 60 patients, underwent blood, urine, and CSF cultures. This is a small number already. Serious bacterial infections were identified in 9 of the 104 cases, or 8.7% of infants undergoing evaluation, in 2.2% of all hypothermic young infants. So this is similar to the number you guys have had of those who underwent evaluation. So this is what you were talking about. Who underwent evaluation? They were younger, they weighed less at birth, they weighed less in the ED, they were more likely preterm at birth, and more likely Caucasian. And the mean temp of patients undergoing SBI was statistically but not clinically lower than the patients who without workup, 35.9 versus 36.2. But that 36 for me is clinically important because that really shows most people still look at 36 as that dividing line for hypothermia. Now, age was the only factor associated with an SBI. The older patients by mean were the ones who had an SBI. So again, this is Table 3, page 13, which you discussed. It's the same as your paper. The older kids, older than that first 2 weeks of life, were the ones who were more likely to have an SBI, which again is fascinating because of the things that we've already talked about.
It reverses the commonly held wisdom, right, Tony? I think that there is something different about those infants under 2 weeks. And the reason that rate seems to be around 2% and pretty standardized across these studies, I think really speaks to just a large number of infants who are in that grouping who are diluting out the infants who have sepsis, and it's just those underweight cold billy babies who are frequently coming in. And it is fascinating how it turns the age and risk of sepsis around a little bit. Very, very different from what I was taught, honestly.
But it also, when you look at their Table 3 on their page 13, when you look at those kids, almost invariably there were other medical issues with the child. or they came in looking. So I'll give you an example. So one of the children had hypoplastic left heart syndrome, bilateral hydronephrosis, came in with cyanosis and low temperature. So cyanosis was also there. One was a twin gestation with bradycardia, with significant bradycardia alarms. One had vomiting, diarrhea, and fever, then had hypothermia. One had abdominal distension, fussy with feeds. One refused to feed, GBS positive mother, hypoglycemic, hospitalized dehydration. One on the right, dysplastic kidney with lethargy, poor eating, and hypothermia. And in the other paper, Catherine Kazmaier, in her paper, they go into this as well, that the children who ended up having SBI hypothermia typically were more likely to have something else. Cyanosis, poor feeding, lethargy, distension. One here had cyanosis, one had color change. One was intubated upon delivery with hyperbilirubinemia, hypoglycemia secondary to hyperinsulinemia, had decreased oral intake. So almost none of these kids had nothing else besides hypothermia.
Yeah. Again, Tony, looks well to an experienced pediatrician.
Yeah.
I think there's something to be said for that these infants are going to give you some signal. And if you're evaluating a hypothermic infant between the ages of 0 and 14 days, and they look well, these data suggest that you could think about being sparing in a workup on that infant. Doesn't say definitely don't, but, it suggests that you could be sparing. So
the summary of this, 75% of the hypothermic infants were sent home did fine. 104 were worked up for SBI. 95 patients, or 91% of them, did not have SBI. And of those that did, they had something else, which, again, is fascinating, which takes us right to our last paper. There's one FIS database study, but I don't know we have time for that one. And I'll just mention it briefly out of respect to the authors, because it was a good paper. Outcomes of young infants with hypothermia evaluated in the ED by Ram Gopal et al. Here, done in Pittsburgh again, Journal of Pediatrics, June 2020, and volume 221. What is fascinating, as a side note, Andy, is all of these papers, besides yours, it's like the past 2 years. All this data has come out very, very recently. So this field is very rapidly changing. So now the paper we are going to spend a little more time on is Hypothermia, a sign of sepsis in young infants in the ED, by Catherine Kazmaier et al., Peds Emergency Care, March 2021, volume 37, number 3. So,
Tony, I got to stop you.
Okay.
Because I think there's something very funny about this paper that made me smile, and I only realized it preparing for today.
Okay.
If you flip to the next page in the paper,
okay,
what's the short title of the paper on the top of the page?
I got to hold on. Let me see. Okay, here we go. Next page in the paper.
The short title is
Hypothermia, an uncommon sign of sepsis.
Now they add an uncommon. So yeah. I laughed when I finally I only picked that up this morning, Tony, and I think it even this paper kind of gets they answer their own question between the initial title and then the short page title. I had to interrupt you because that made me smile and is also a really important point.
And there's not a question mark there to where they're asking. No, that's a statement. That's a pure statement.
It's great.
That's great. So now they talk about hypothermia and temperature instability can also be presenting signs of sepsis or HSV. The goal was to examine the diagnostic value of hypothermia for sepsis in infants. The objective, determine the prevalence of SBI, which is diagnosed as UTI, bacteremia, meningitis, and HSV infection in infants with hypothermia in the ED. Then they wanted to evaluate other clinical features associated with serious infection in hypothermic infants and determine ultimate diagnosis for hypothermic infants. I love that second part because they gave us a lot of rich data to look at.
Yeah. So
their methods was a retrospective study of infants less than or equal to 60 days of age seen in Urban Children's Hospital ED from April 26, 2014 to February 27, 2017, which was very specific dates, which I'd love to know the significance of. Primary outcome was presence of SBI, also bacteremia, pneumonia, which was diagnosed as chest x-ray with the clinical case supportive. And there was consensus from all authors, including the ED and the ID experts for these patients, which I thought was very nice because it strengthened the data set, as opposed to the other paper, which was one person had to agree. This, they all had to agree.
Yep.
Infants were considered negative for serious infection if serious infection was not diagnosed in the following 7 days based on review of the EMR for return visit to the institution. And they discuss, similar to our institution, theirs is the only one. There's not really anywhere else for babies to go. So the inclusion criteria is infants less than or equal to 60 days old, seen in ED during the study period for any reason. Exclusion criteria is no temp recorded in ED, left without being seen, outside hospital infection evaluation workup done, and then fever in the ED, they were excluded. And again, they defined hypothermia exactly the way you did, as a rectal temp of 36 degrees Celsius or lower. Only rectal temps were included in the study. So looking at their results, they had 4,797 total ED visits by infants less than or equal to 60 days old during their time period. 116 had hypothermia on rectal temp when rectal temp was included. Interestingly, a lot more had fever. 418 had fever, so like 4 times the number almost had fever. 3 to 4 times. So more than a third of the hypothermic infants are less than 7 days old in their study. So a big, big number are very, very young. They were then 72% of the hypothermic infants were not evaluated for SBI, same as the other study. No infections were missed due to incomplete evaluations, but they did say hyperbilirubinemia was the most common diagnosis for hypothermic infants in 16.4% of them. And they also had a slew of other diagnoses. 5.2% had hypoglycemia. 15.5% had feeding issues or dehydration. And they go into this, let me pull it up in extreme detail here. Bronchiolitis was 14.7%. Brew was 10.3%. So they go through all of it. And they found the prevalence of SBI was significantly lower in hypothermic infants, 2.6%, which is eerily close to your 2.8%.
Just saying.
That's very, very close. Then febrile infants, 15.2%. They also had UTI as the most common serious bacterial infection identified in both hypothermic and febrile infants, which makes sense. That makes me feel like this data makes sense. The FIS database study, why I didn't love it, is they found bacteremia was the most common, which I've never seen anywhere else. No. So it's made me question, again, what we talk about. Those databases are good for some things, not for everything. Blah, 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 blah. Hypothermic infants with SBI all had additional potential signs or symptoms of infection. And this is what we talked about in our last study. They all had something else, including apnea, poor feeding, lethargy, and ill appearance. All hypothermic infants with SBI were also premature in this study, every single one of them. So 77 or 66% of the hypothermic infants had none of these concerning historical findings. The prevalence of SBI in these is 0. But the concerning historical findings themselves were not specific. 33% of hypothermic infants had at least one of the findings, but relatively few had SBI occurring among the high-risk infants. So then more studies are needed. So it's a specific sign, not a sensitive sign. Am I right there?
Right. I would say that completely.
Okay. And in terms of screening, you want which one is more important? Because you went into this. So for those listening, we recorded this recently a week ago, but I made a technical error. And somehow the recording came up of all Andy talking, and I was completely silenced.
Which I was fine with, but you insisted on being on the podcast.
So you mentioned that. Can you discuss that, especially for our residents or our medical students listening in? For screening tests, you want to test with a.
Yeah. So I think this is the big difference between screening and diagnostic testing. Screening testing. Just to remind everybody, and this is just going back to base principles. Good screening tests have tremendous sensitivity. And you can think of that in terms of actually the febrile infant screening that PCARN put forward. It has tremendous sensitivity because you don't want any false negatives. You don't want someone to slip by who has an SBI that you didn't know about, which is a false negative evaluation. And screening tests in general are designed that way for a very good reason. It's a screening test for any disease in that you're going to accept poor specificity, which is what the PCARN criteria are. They identify a number of infants who are positive by their screening criteria who are not going to end up having an SBI. They're falsely positive. But we don't want to miss anyone. And that's, when you think about it, things like cancer diagnostics adhere to that too. We don't want to miss a cancer in our initial screen. But when you're doing two-tier testing, you almost always are going to want to have better specificity for diagnostic testing. I really don't want my diagnostic testing, I don't want my blood culture to have very poor specificity, because if my diagnostic test, which confirms a diagnosis, has poor specificity, I'm kind of screwed, to tell you the truth. False positive results are the bane of our existence with diagnostic tests. But screening tests, you really want to focus on that screening being very good to exclude missing that one infant who may have something very serious going on.
That's great. Thank you, Andy. So now, due to the high, they discussed this, due to the high prevalence of hypothermia in younger infants, a third of those that were hypothermic were around that 7-day-old mark, less than 7 days old. Maybe they think maybe this is a normal part of their physiologic development that we as of yet don't know. Hypothermia can also be a sign of hypoglycemia. They talked about 5% of the infants with hypoglycemia had hypothermia, or vice versa. And they discussed that several studies have found hypothermia and apnea to be the most common presenting signs of late onset sepsis in premature infants in the NICU, with hypothermia being a specific sign as well. So that's NICU data that I did not know, which is always very helpful for these premature kids, right?
Yeah, but I also think now you're talking about a completely different set of children. I think this is where it's just so important to do the study in the setting you're doing. The phys data, I think, Tony, looks so different.
Yeah.
Simply because you're not looking at a granular slice of infants coming into an emergency department with a low temperature and then being admitted to your floor with a low temperature. So you are the hospitalist. You're seeing this kid in the ED, or you're seeing this kid as they're admitted to the floor. And that the phys data probably got a lot of infants who are very medically complex, or got transferred in, or maybe were in the NICU, or just recently, because it's such a diverse set of hospitals along the way, it's probably got a much broader range of infants. Whereas these focused looks, I think, are more informative to us, because these populations sound like the patients you and I take care of, right? They really do in these studies that are the single center. And so it's very reassuring to me then that all these data line up across these papers. It's actually kind of interesting how closely they adhere to each other. For hypothermic infants, a base rate of sepsis of around 2%. For most of these studies, between 2 and 3%. That the infants who were hypothermic who had sepsis tended to be the older ones, not the younger ones, as opposed to the febrile infants. And that coming out of all three of these studies, and Kazmaier does the best job kind of elucidating it, there's a physiologic reason here that may underlie this observation, that when we get these infants in, we may be observing the normal physiology that's associated with hypothermia in the youngest infants. Yeah. And in the older infants, we need to take it seriously. Having read these studies and reviewed them, I set aside the phys data to say that's an interesting observation for all hypothermic infants across the hospital. But when you and I are thinking about an infant in the ED or freshly admitted to the floor, you tell me that infant's less than 14 days, I'm going to feel better about their low temperature. You tell me that infant is 6 weeks old, I would probably say, Tony, let's definitely do a workup. I'm worried about this kid.
There's one more set of data that I want to read one more thing I want to read about this paper. And then I'm going to tell you what I took away as a hospitalist. Please. And how I'm going to go about it. So first, one out of 3 of the hypothermic infants with serious bacterial infection in this study had HSV. And previous studies found that infants with HSV are either normothermic or hypothermic. This was the first one to really point that HSV could be a cause. And so what I took from all of this is similar to what you were saying. If I have an older infant, if they have another reason for coming into the hospital, I'm going to get them after the ED typically. So if they came in with cyanosis, especially breathing issues, apnea, if they look lethargic, if they're not feeding well, I'm going to take a closer look at them, and I am probably going to want HSV in the workup along with my blood, urine, and CSF cultures to really round out my look at them. But if they're less than 2 weeks old and they only came in with a low temp in their PCP's office and they're doing well otherwise, I am going to feel a little bit more comfortable with that infant, that there's less likely to be SBI.
So I would look at that. I would first of all remind you of the tyranny of low numbers. So, there were only 3 infants who had SBI in their sample. And so extrapolating from them is tough. One of them did have HSV. What I extrapolated out of this was more, I'm not going to think about HSV in those other infants at all. But when this infant does not look well, lethargy was part of that infant's presentation. We need to pay very close attention to good exam findings. That infant was lethargic. And then when you examined that infant in this study, lethargic, hepatomegaly, apneic, delayed cap refill, you can talk me into almost any workup on that infant. Because you said apneic, hepatomegaly, lethargic, absolutely HSV.
Sure.
And this is actually one where I think almost all a complete workup top to bottom, including a chest film, is probably warranted immediately because that infant is selected. These studies were almost reassuring to me that being a good clinician is going to protect you a lot. Because these infants all had something going on symptom or on sign on exam that helped to identify them. So I would say take some comfort that being rigorous about your history, being rigorous about your exam is going to turn up most of the infants you need to worry about.
I could not feel better about it myself, Andy. This was really helpful because we're seeing more of this. I love that this data has been done in the past 2 years, a lot of it. Full disclosure for those listening, 3 out of the 4 studies we went over do come out of Pittsburgh. So could we be biased because we love our colleagues? Sure. But we tried to be as objective as possible. Quick announcement for everyone listening, and then we'll do our send out. Remember, PHM 21 virtual conference is coming up. Again, full disclosure, I am on the planning committee and the executive committee for the AAP section on hospital medicine. But this year's conference is going to be great. We did get fantastic plenary speakers, including Drs. Fauci and Beers, to be at our conference. So I suggest if you're able, it's virtual. You can do it from anywhere you want. You'll have access for 3 months. Consider coming. I will be there. Now that that's done, Andy, I cannot thank you enough for your time. I know you're incredibly busy. I really enjoyed this. Before we say thanks, is there anything we didn't talk about that you wanted us to talk about?
No, I think we hit the points of this. And I think this, Tony, I'm passionate about research. And so I'm glad you pointed out that 3 of these 4 papers were from Pittsburgh. This is a good reason for you to think about at other institutions, taking a look at your own data. The Connecticut paper was designed slightly differently, and yet it added to this data set. It was very rich information that helped to confirm and enlarge some of the findings from the other papers and helped us learn more.
Yeah, no, it was very well done. Andy, thank you so much. Thank you and we're going to be seeing more of Andy. We got a 3-part series with him on different aspects in ID. So we're going to see a ton of them. We love them. Thank you very much, Andy.
I'll see you next time, Tony. Thanks for the invite.
My pleasure.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, Tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.